Hi, Tolu.
Hello, how are you?
I'm good in yourself. Hi, Nipa.
Well, thanks. How was the travels?
It was good, thank you. Good to contact with you again. I'm not supposed to join at this time, but I just wanted to check in to see if everyone is okay, um, and if you are all good.
Yes, we're just doing, I believe, a quick run through, and then we're just waiting for Vanessa to join.
Okay, all
Um,
right.
yes.
That's good. Do you need me to be here? Would you like me to be here?
I think we have everything under control right now. If there's an emergency, I think we'll pop a message.
Okay, all
And
right.
yeah.
And all right, so you guys know how this is done. But I see Prophet Balmik is joining, so let me just greet him and then I'll tell him that he's in the hands of the students. Did you ask him to join a bit earlier?
No.
Oh, okay.
Yeah.
Okay.
Mhm.
Um, all right, but I also have to just move computers and move rooms and plug in my computer. So I think what I'll do is I'll just join at 10:45 as I normally do.
Okay, that's
Right.
perfect.
Okay. Thank
Mhm.
you. Bye.
Bye.
Hello, everyone. Who's recording?
Hi, Vanessa. I also don't know if it's recording. I just joined and it said it was recording. So I'm not sure
Oh,
how I stopped it. And then I tried to claim host, but it's asking for a claim key. So I'm not sure
oh, hectic.
how to stop the recording situation.
Should we
How are
hop
you?
onto a Microsoft quick link, a quick call, just the
Yes,
three of us?
yes.
Okay.
Hi, Jimmy. Welcome. Hi, Jimmy. I'm just checking if you can hear me.
And just checking to see if the system is working okay, whether the internet is stable enough. I don't know if you
It
saw
seems to
my
be good.
email.
No, I didn't see your email. Did you send it recently?
Okay, just about a
Um, no,
and
about half an
already,
hour ago.
yeah, it didn't
Oh,
come through.
no. It's still finding its way
Oh dear. Anyway, what it
undersea
says,
cables.
yeah, besides the fact that you know, sorry, I said
Oh, connectivity is not great. Adipa, is it just me that can't hear, Prof? Kanipa, is it just me that can't hear, Prof?
No, I think that he's lost signal.
Okay. Yes.
Thing.
Okay. I think we lost you intermittently there.
can you hear me now?
Yes, we can, but I think you may have to switch off your camera.
Oh, right,
Yeah.
right. Yeah,
I'll
that's
switch mine
probably,
off as well.
yeah. Let me just do
Right.
that now.
Sure.
And,
I'm just
that should-
doing the introductions and the discussions with
Okay.
you, Jimmy. We handing over to the students now to run the webinars. So
Right.
I saw one of the students join for a few seconds. So the other one is here, and as soon as they're formally here, I'll do the introductions as well. Oh,
Okay,
there they are.
yeah, Renee, just one thing.
Yes.
I don't know if you heard that part earlier, but I've got a meeting with the Gates Foundation at 6:30. I
Okay.
thought this webinar would only be 1 hour, so I accepted
Okay.
that meeting. I'm afraid just a couple of minutes before 6:15, I'm going to have to leave.
Quarter
I
past
hope
6.
that's like, yeah.
I'm sure that won't be a problem. Prof, let me just introduce you to the students who are going to run this webinar. Some of them
Okay.
you may know, Vanessa Anandide, final year medical student.
Okay.
Kanipa Tsalanga, 5th year medical student, if I'm not mistaken, and Tolu, she was here. I don't see her name, who is a 2nd year medical student. Oh, there she is, Adeboye. So they are going to be facilitating. So I'm going to hand over to Vanessa. Vanessa, Prof has to leave at 15:15. Is that okay in terms of your program? I know that we're supposed to be running this for 1.5, not 2 hours anyway. Over to you, Vanessa.
So Prof, we are planning for it to be an hour and a half, maximum. But I don't know if because the initial plan was Prof Jimmy speaks first, and then Dr. Chuki goes next, and then thereafter we have the Q&A. Just to avoid having a situation where there's too much Q&A time for one speaker and then the next speaker is rushed. But in light of Prof having to leave was it 6:15?
Yes.
I'm not sure if we should perhaps maybe give Prof Forming a few minutes after he speaks that.
I think let's do that
first, and then so we'll just edit that so that Prof Forming does have some Q&A time directly after he speaks, just so in case, yeah. So if he can't stay for the full Q&A at the end, then that isn't an issue, and people do have time to ask questions.
Okay, that's great. Thank you. And then I also just wanted to check, Prof. Alming, your slides. You happy to present from that side? If you are able to send through a copy so that we can just have a backup in case there are technological challenges, that would be wonderful. Can send it to me and I'll just forward it to the rest of the team. Still there? Is Prof still there, everyone? Vanessa, do you see Prof?
He just rejoined now. I was also checking also disappeared from that.
Okay,
I think he just Prof is back now.
Okay, all right. Jimmy, I think we lost you again there. If you are able to send me your slides in the interim, just so that we have them as a backup, that would be great. And then Vanessa, go ahead.
Yeah, no, I have sent it about half an hour ago, and it shows up in my sent file, but clearly it's sitting somewhere in the Ethernet. Maybe it will come through.
You sent it to me.
I did send it to you and to Ms. Blouse.
Oh, okay.
Yeah,
I don't have them.
okay.
Did you send it from your welcome email address?
I sent it from the welcome email address, yeah.
Okay. All right. I'm sure it will come through, but we will remain hopeful. Vanessa, just so that you know, Prof is in Blantyre at the moment, so there may be some connectivity issues, just in case.
Okay, noted.
And yes, Tom. Hi, Tom. How are you? Welcome. Hi, Tom. Okay, over to you, Vanessa. It's on the hour.
Hi, Prof. I'm just letting you know that I got the email from Prof. Jimmy and I'll forward it to the group.
Oh, great.
Thanks very much. Tom, if you can send your slides as well, just as a backup, that would be great. But I see it's almost 5 o'clock, so I'm going to hand over to the students to start when they are ready. Thank you.
Thank you, Prof. I don't know if you can hear me.
I can, yeah.
Okay,
yes, we can. Thank you.
Thank you, Prof. Jimmy. Thank you, Prof. English. I want to welcome everyone today. Thank you so much for joining us this afternoon. So this is our second. I'm so sorry. I don't know if I can show my face. Let me see. Okay, yeah. So thank you so much for joining us this afternoon. So this is our second webinar out of 6, and today's webinar is on equity and global health and African perspective. And the purpose of today's webinar is to explore the intersection between equity and global health through the lens of African experiences and perspectives, and also to inspire action and collaboration towards promoting equitable healthcare solutions worldwide, with a particular focus on addressing the needs of marginalized communities in Africa. And we have very excellent guest speakers tonight, and we hope that everyone will enjoy their presentations. And I will now then hand over to Tolu to introduce the core team. Tolu, I think you're muted.
Oh, I apologize. All right. Good evening, everyone. My name is Toluwani Adeboye. I am a third-year medical student at Stellenbosch University, and I have the privilege of introducing the core team of this initiative. It doesn't take one person or two, but a group of people that can make this vision come to life. Part of our core team is Professor Renee English. She's the acting head of global health and the head of division of health systems at public health at Stellenbosch University. We have various students involved, such as Vanessa Anand, who's a final year medical student, Tlakanipa, who's in 5th year, myself in 3rd year. Going on to the rest of the team, we have Stacey Blouse, who's a PhD student. We also have Walile Dube, Dr. Juliet Nyasulu, and Dr. Lynn Hendricks, and they are beautiful faces are showcased on the screen. As this is an ASU Global and Public Health initiative, we are not alone in this endeavor. We have various students represented all across Africa, namely Ghana, Cameroon, Kenya, Sudan, Malawi, Uganda, Liberia, and Nigeria. And so we hope that from my team to the rest of you on the Zoom call, we hope that you enjoy this webinar and that you gain something. And I'll now hand over back to Tlakanipa to carry on with the program.
Thank you so much for that, Tolu, and thank you for introducing the team. We will now hand over to Prof. English to give an overview of our initiative and to just speak on the aims and the inner workings of what we are trying to do here. Over to you, Prof. English.
Thank you. Thanks very much. And really happy to see everyone here today and the students. And as had been introduced by Tolu earlier, this is very much a collaborative initiative between us as the faculty at Stellenbosch University and the students. And so I want to speak a little bit about the Stellenbosch University Africa Global and Public Health Student Network. What we hope to do collectively is build an African global and public health network, which really could function and should function as a community of practice that is student-focused and that aims at enhancing the knowledge, the practice, and the skills regarding priority, current, and future global and public health issues that are relevant to the African continent. And what we hope to achieve are transformed students who ultimately become change agents and leaders in society. We very much believe that this is the next generation. You are the next generation of leaders, health practitioners, and clinicians on the continent. And our aim is to be able to see you make a viable contribution to our continent and the growth and the health of the population on the African continent. And importantly, to co-create this project with students and build networks into Africa and share learnings and experiences. And I'll speak a little bit more about that now. Next slide, please. And so the context of this initiative really also speaks to what's happening on the African continent, particularly in terms of the work that the African Union is doing and Africa CDC, how they've prioritized public health on the continent, particularly given how Africa fared during COVID-19 pandemic. Contrary to what was expected, South Africa did not fare too badly. However, there were some challenges that had been uncovered by COVID-19, and it was fortuitous that at the same time there was a lot of work happening at Africa CDC to address some of the challenges on the continent. And this also led to the development of a strategic document, which was called the New Public Health Order for Africa, which seeks to address deeper structural global health deficiencies at national, regional, and global levels. And so we want to speak into the sea change that is happening on the African continent. Next slide, please. And so what is this initiative all about? So we had a launch a few weeks ago where we spoke about the initiative, introduced it, and that was well attended. And we had speakers talk about the vision for global health in Africa. We are now starting formally the Introducing Global Health webinar series, where we take an African lens and apply it to topical issues within global health. Why are we doing this? The students who are part of this network are students who approached me over the years when I taught them public health and spoke about global health issues and said, how can we become more involved? And at our university, we also introduced a renewed curriculum. And so we had some students who were exposed to public health as it was taught previously, and other students who were exposed to global health and public health as we started to teach it in the renewed curriculum. Similarly, for postgraduates and other students, we run a short course called Introduction to Global Health short course. And it was about how can students become knowledgeable, capacitated around and be able to speak to issues around global health. And that's what sparked this initiative, but it's also what sparked the Introducing Global Health series. Second of all, what we hope to do is to leverage the power of social media communication and challenges, which we hope will be able to stimulate dialogue and critical thinking. So this particular initiative will go onto our website and will kickstart a broader range of conversations around the topics that are presented here. And so in essence, we want to bring this process to life as opposed to have webinars that just take place at one point in time. And then we will also be offering additional capacity building sessions. So we are collaborating with other academics and practitioners who work in the space of social innovation and design thinking, and these are planned for later on in the year. And we also hope to have field visits. But through the networks, particularly through the networks of the students like Vanessa, Didi Anan, who has great networks into Africa, and our networks that we have as staff, we are hoping to be able to replicate some of these activities within the African continent over time. Okay, thank you. Next slide. And so the vision is that of change agents who are transformed and in turn transform the worlds within which they work and they live and they play. And so this is my encouragement to the students who participate in this initiative. This is my encouragement to the students who are the future public health and clinical practitioners and global health practitioners representing our continent and beyond. Next. And so this graphic really is meant to inspire you. What is it that you love? What is it that the world needs? What are you good at? And how can you, within your workplace, within the things you do, combine your passion, your mission, and your profession to fulfill your purpose? We are all put on earth for a purpose. What is your purpose within this African continent? And how can this particular series help you to achieve that purpose? But what can you give that will enable you and others to achieve theirs? And so I would also like to highlight this lovely quotation which says that awareness is the greatest agent for change. And so as we continue through this webinar series, as Prof. Volming and Dr. Choki speak about what they will be speaking about, we are raising awareness to become agents of change. And so my final words are, next one. Start with what you have, start now. Thank you. Back to you, students. And while we're transitioning the slides, part of what we're wanting to do is to make this a student-run initiative. And so the webinars will be managed and run by the students. Thank you.
Thank you for that very wonderful presentation, Prof. You know, you've definitely encouraged us to engage with our purpose and what we are here to do on Earth. So thank you very much for that. So now we will hand over to Vanessa. Vanessa will be introducing our first guest speaker today. I'm really, really excited to hear this presentation. So over to you, Vanessa.
Thank you so much. Can someone confirm that they can hear me?
Can hear you.
Thank you so much. I have the privilege today of introducing Professor Jimmy Volming, who will be the first speaker to speak on the topic of equity and global health in African perspective. So Professor Jimmy is the Chief Diversity and Inclusion Officer at the Wellcome Trust, which is a charitable foundation which is focused on health research. After obtaining his BSc and MPhD degrees from the University of Cape Town and a DCH from SA College of Medicine, he worked in hospitals in rural Swaziland and Cape Town. From there, he went on to practice as a family physician and district surgeon in a township near Cape Town for 12 years. He was awarded a Harvard South Africa Fellowship and obtained an MPH from Harvard University in 1988. In 1996, he obtained a DPhil in epidemiology after receiving the Nuffield Research Fellowship to further his studies at the University of Oxford. He was elected to membership of the Academy of Science of South Africa in 2000 and has served 2 consecutive terms as the ASAF Council member. Jimmy Volmink was a former dean of the Faculty of Medicine and Health Sciences at Stellenbosch University. He was the founding director of Cochrane South Africa and the founding director of research and analysis of the Global Health Council in the United States. He has widely been recognized for his contributions to evidence-based medicine, as well as his contributions to health and well-being. Prof. Volmink, we are honored to have you here today, and we're looking forward to hearing you speak on the topic.
Thank you so much for that introduction. But let me start by really just congratulating you on this wonderful initiative. I think this is going to be very stimulating, I'm sure, for everyone concerned, and will certainly the interaction that you will have will deepen your understanding of global health and public health issues. So well done, and you know, we really need to see more of this kind of initiative. When I accepted the invitation from Prof. English to speak, I thought I was going to give this presentation from my current base, which is in London at the Wellcome Trust. But it turned out that I am now sitting in Blantyre, Malawi. I've just arrived about an hour ago. And in a way, I thought that this was probably more appropriate to speak on, to be here when I speak on the topic that was given. So I'm very happy to be here with my mosquito nets and sitting in my room in a guest house here. And so I look forward to this engagement with you. The downside, of course, is that and the simplicity of being in reality of the African situation is that the internet is a bit unstable. So I hope that you will be able to continue to hear me. If there's a problem, please let me know. I've turned off my camera so that you know, we don't chew up the bandwidth with that. So hopefully things will be fine. So let me, if I can get the slides shared. Let me just open this. Let's just see. Okay, can you give me some indication whether you can see the slides?
Yes, we can see your slides, Prof.
Okay, all right. So, right. So let me just say that slides don't move at the moment. There we go. I'm going to give a fairly high-level introduction. Probably my understanding is that the meat of this is follow, which is the open discussion. So I'll just show a few slides by way of introduction. Okay, so the first question to ask really is, what do we mean by global health? And there are different definitions of global health, but perhaps the most and traditionally is that it is what people from the global north do in the global south, to be brief. This sort of extract here, this quote is from Randall Packard's book, which is a very good book, and I would recommend it to you, A History of Global Health, where he talks about the core of global health being about efforts to improve the health of people living in countries in the underdeveloped or third world settings. And that is pretty much how many people, most people interpret the term when used. Now, global health didn't drop from nowhere as a discipline, as an area of scholarship. It is quite deeply rooted in what brought into being to serve the goals of the empire, and not because concern for the and the problem with global health being kind of embedded in that history is that it continues to reflect the colonial values, some colonial values, attitudes, and practices. Now, what am I talking about? Here, I hope you can see, are some of the key features of the antecedents of global health, and some of these things you will recognize in current global health practice as well. There's always been a real focus. Clear, these were not threats. They were not engaging because of the threat to the local population, but the threat to the colonial population, either the people doing, the army or the administrators who were coming from the global north into environments where they'd never been exposed to certain infections. And so a whole area of research and practice around diseases came into being. And it's interesting today, if you look at the Gates Foundation, if you look at Wellcome Trust, you look at many of the global funders, they still continue to focus on infectious diseases, despite the fact that non-communicable diseases are rising at a faster rate than anything else, for example, on the African continent. The second thing is the way diseases were controlled, and the word control still sends chills up my spine, disease control, because it harks back to a time when people in the global north who were involved in tropical medicine, for example, were using, fairly top-down military-style disease eradication campaigns, whether it's to deal with malaria, yellow fever, or any of the others. Without really a regard to the contribution that local The third is biomedical technologies, and I'm not opposed to biomedical. I think biomedical technologies are useful, but there is a heavy reliance on biomedical technologies, often targeting one disease at a time, and so vaccines would be a typical example of that. And again, they have their place, but if you look, for example, at tuberculosis, we've known what causes tuberculosis because of biomedical research. We know we've developed drugs. We even have a vaccine in BCG. But TB is still a huge problem in the world because we have not dealt with the underlying issues that predispose people to TB disease and infection. And then the fourth thing, perhaps, is the neglect of health systems and so. So why should the colonialists, why should they be interested in health systems and social factors impacting people, the health of people in indigenous settings? If the endeavor was there to protect them rather than the people in those countries they were operating. And so still today, getting money to deal with health system strengthening or to deal with the underlying social issues that impact health, still a huge challenge because nobody's interested in funding that sort of thing. Lack of cultural sensitivity and victim blaming. Yeah, that was a pretty common thing in certainly in previous times. I think people are becoming a little bit more aware now of the need to, cultural setting in which they operate, and get people involved in solving their own problems. But we've got a ways to go in getting that off the ground. Devaluing knowledge and abilities of local communities. So this is the typical power imbalance where people from the global north are seen as the experts, how to solve our problems in Africa. Africans essentially don't have any valuable knowledge or an ability to deal with their own situations. And then the last thing I wanted to mention was there's a history of unethical medical experimentation as well in African and other settings. So all of those things, we've seen over the years, and some of them still surface in the global health practice and policies. So let me just briefly give you some examples of to illustrate what I've just said. So here is a cartoon from a newspaper in 1926 in London, where there was a call for money to deal with malaria in Africa. And what the cartoon says, bluntly, was essentially, it says, money or malaria, don't cry help, send cash. And on the rock there, you'll see it says malaria is crushing the life out of our tropical industry. So you can see the motivation behind, them wanting to get involved in dealing with malaria in Africa. Here's an example from the Philippines, where poor sanitary habits of Filipinos were blamed for as a threat to American troops and administrators. And in a very paternalistic manner, this US Army doctor writes, they appeared to me like so many children who need a strong hand to lead them to the path that they are to follow. And so the answer was top-down, military style, interventions to deal with these problems. And then just lastly, the German colonization. Here we see in East Africa, where there are really horrific examples of experimentation with drugs for trypanosomiasis that were, really unethical practices that they could get away with because they simply had the power to do so. Then I want to touch on the issue of race, because you can't really talk about colonialism without talking about race. There's such a strong nexus between race, colonialism, and in fact, slavery. And so just very briefly, this concept of race is a fairly recent construct. It arose in Europe as a way of distinguishing between people from different continents. And I want to go into all the details of that, but it was driven by socio-political concerns with a guise which was sort of pseudoscientific. In developing the idea of race, the Europeans felt that they could distinguish people in the world based on, separate physical, moral, and behavioral traits. So they would start with the physical. People would be classified by the color of their skin, their facial features, their hair, and at some point is also the shape of the head, etc. And that those physical characteristics were believed, and this was the myth that was propagated, was believed to be associated with certain moral and behavioral traits, none of which were complementary unless you were a white Anglo-Saxon. So this was actually a hierarchical classification, with those who were doing the classification, i.e. the Europeans, always featuring at the top. So whites were at the top, Black Africans were always at the bottom, and then everybody else were somewhere on that spectrum. These racial differences were believed to be inherited, and that you couldn't change them. Once you were born, you were stuck with them, and you had to know your place basically in the world because of who you were. And again, some of these things you still see playing itself out today. But that was sort of embedded in the whole racial classification. And so this idea of whites being supreme, being at the top of this pyramid, was used to justify why they could enslave people. They could go to people's countries and rule, because that was their God-given right to do, because of the fact that they were white. And science is always very supportive. So science is not value neutral, right? So science in these times, and in fact still today,
Hi, have we lost Prof?
I also can't hear him from my side, Prof.
So I think it's the network. Let's just give him a moment to reappear. So I think he's just reconnecting at the moment. So for those, welcome those. I'm going to hand over to Vanessa now. Vanessa, if you can just update everyone where Prof is, and maybe just go through the list of where everyone's joining us from. Thank you.
Okay, thank you, Prof. So as we wait for Prof. Fulmich to rejoin and continue with his presentation, I will just briefly go through the chat of where our participants are from. So we have people joining from Uganda, from Malawi, specifically Blantyre as well. Seems like a majority of our participants are from Cape Town. We have some people joining from Kenya, from Cameroon, from the Netherlands, and Nigeria as well. So that's primarily where our participants are from today. Although our network from the people who've joined us does expand to other countries like Cameroon, Liberia, and Ghana. So nice to have you all with us, and just ask that you bear with us as we sort out the technical difficulties. More people from Kenya. Thank you, Sharon.
I also know that Prof is on a tight schedule. So if you have any questions, I guess you can maybe start typing those questions in the chat box, or you can maybe start writing them down so that when Prof finishes with the presentation, you can ask them.
It's Dr. Nyasuru here. I've got a question in the chat. And the question goes, of course, to Prof. Vomic, but I think even the experts in the house can also assist to deliberate on this question.
Thank you for your question, Dr. Nyasulu.
I'm struggling to see the question. Is it possible for you to go through the question with us, please, Dr. Nyasulu?
Okay, thank you very much. Can you hear me?
Yes, we can hear you, Doctor.
Okay, so I've addressed the question to Prof. Vomic and the experts in the house. And when I'm talking of experts, I don't just mean the professors and doctors in the house, but I know that even the students, wherever we are coming from, we could be experts in our own space. So this question is talking to the fact that in Africa, we do have our own tested and tried solutions to address our public health and health systems gaps, which we're experiencing. However, most of these, when we're trying to address these gaps, the financing comes from the North. So my question is, what advice would you give to us Africans to focus on testing and implementing on our own African solutions without the influence from the global North, even though the funding comes from there? How can we control the influence on our approaches to solutions? Because we do have our own African solutions to address our own African challenges. But how do we control this influence? That's the question in the house. Over to you.
So if I may, Flankanipa, answer that question. So thank you, Juliet, for the question, and I'll speak until Prof. Vomic can join us again. So I'm happy to just be told when he can join us. But I think it's a very important question, and it's exactly that question that is part of why, at a personal level, I think that these kinds of conversations are very important, because we need to start interrogating things like power dynamics. So we're speaking about global health. Prof. Vomic is undoubtedly, we're still going to get to that in his presentation, the asymmetry of power that exists between the global North and the South, the asymmetry in terms of funding organization, who funds which organization, who makes the decisions, how unified are we as a continent. We must not forget that there's sub-Saharan Africa, but we have Southern Africa, West Africa, East Africa, Central, North Africa, very different sets of regions, different languages. We have Anglophone, Francophone. But last year, I participated in a study called the Future of Global Health Initiatives. It was a study that looked at 6 global health initiatives. So these are included the Global Fund. It included the Global Fund. Okay, if someone can just mute themselves. It included a range of very large funders who are responsible for funding and also very much driving the agendas of what is researched in the South, particularly within Africa. And we looked at Senegal, we looked at West Africa, and East Africa, Southern Africa, and we looked at IMRO. So we also included case studies, Senegal, South Africa as a case study, and Pakistan as a case study. And what came out very clearly, regardless of the country, because we applied, it was a consortium of researchers, and we applied a particular an analytical lens called a political economy analytical lens. And a few things were clear. First of all, it very much depends on the health system of a country. And in a continent like Africa, we have very diverse health systems. Second of all, you were speaking about financing. When we talk about inequity in Africa, we're talking about inequitable financing across the continent of Africa. So in a country like South Africa, where there's a relatively mature domestic resource mobilization history, we only get a very small percentage of our funding to address diseases from outside donors. We raise, as a country, most of our funding ourselves, whereas you get other countries within Southern Africa where that is not necessarily the case, and they're very reliant on external funding, Global Fund funding, USAID funding, others that we can mention, to be able to address the various disease burdens that exist within those particular countries. And for as long as a country is dependent on an external funder with a huge amount of funding, and who themselves have a board, who themselves are recipients of funding from donors, from philanthropic organizations, from other countries, there is this inherent power asymmetry. And so the countries set the agenda, the donors set the agenda, very much the North that sets the agendas in terms of what gets researched, what are the conditions of the research, what kind of capacity do they build within the country that they are working in or financing activities. Do they build any capacity at all? Are they financing and funding human resources within the country to provide support? Or are they financing externals, so those from the South, to come and live and work within the African continent countries to be able to provide support? It's who sits on the boards, who makes the decision, what is the voice of those in the South when the big decisions are made around a setting agenda. So I know that there are some, I see some names on the call of people whose primary objective or primary research concerns are non-communicable diseases, for example. So why are we not applying funding within countries for non-communicable diseases? Who makes those decisions? And so when we took a specific Southern African focus, what became very clear is that as a continent, we are not necessarily unified enough in terms of mobilizing and consolidating our own needs and being able to go to the UN, to be able to go to these large funders and state our case in terms of what it is that we're funding to push a particular agenda. And so that led very much into conversations, and I'm coming back to my earlier presentation about what is the role of Africa CDC, what is the role of the Africa Union, what is the role of WHO Afro, what is the role of SADC in the South? And these are the questions. So it's a very long answer, Juliet, to your question, but it is a very pertinent question around why is it that we cannot unify as a continent, go and state our case where decisions are made around policies and influence. So part of what I'm hoping will happen with such an initiative, as we as academics and practitioners, and I see Ada Adaji was my fellow on the Kofi Annan Fellowship. I saw Claudia Shulumani earlier, not sure if she's still on the call. Oh, she is there, who is extremely experienced from Village Reach, who have worked in the African continent for many years and have built up a reputation. They too can speak to and attest to some of the challenges that exist when we try to unify ourselves and unite as a continent to be able to garner funding from these large international organizations. And so what are you as the students going to do? How are we going to train you to be able to understand these power dynamics, to be able to sit at the table, to have a seat, to be able to say something at the table, to make a contribution? Where are you going to work? Are you going to work in United Nations agencies? And Tom Machoki can also speak to that, who's our next speaker. So I'm taking up a lot of valuable time. I think we have now lost Prof. Volmink very sadly. Just for those, again, to say that he's traveled to Malawi and he's stationed in Blantyre. And I think we have a case study here in a few things. The first is we are on the African continent. We are trying to create networks across the African continent. We're trying to build capacity across the African continent, but we have connectivity issues. So what does that mean for us in terms of just trying to lobby for something simple that we want addressed on our health system. The second thing is, and this is a lesson, because this is it's a community of practice, and for those of you who understand what community of practice means in the world of higher education, or just education in general, it has a very specific meaning. It means that we bring novices into a group with experts or experienced people, and we pass on and we co-exchange knowledge and ideas. So this is also a lesson for all of us, including the young people, to be able to think of on our feet. How do we manage a webinar where we've lost connectivity and we are addressing a particular topic? So thank you for bearing with me. I'm going to just hand over to you, Juliet, to see whether you're satisfied with my very long answer, and then over to Nipa to take it to the next level. Thank you.
I'm not sure if Dr. Nyasulu is, yes, she is still here with us. Would you like to say something, Dr. Nyasulu?
It seems like we have connectivity issues even here in Cape Town. Thanks, Claudia. I just saw in the message, yes, you in Malawi, our teams are struggling. Yes, so connectivity is a real issue. Are there any, and how can we work across sectors to be able to, on the African continent, start solving this problem? Sorry, I see Heike Geduld here as well, who's also worked a lot with our colleagues across the continent. I see Prof. Wilmink is back. So Jimmy, I see that you are back. We had a nice exercise in being able to think on our feet and fill the time with questions and answers while you were gone. So let me see if you're feeling prepared to continue with your presentation. Thank you. Over to you, Nipa.
Thank you very much, Prof. Prof. Wilmink, could you please let us know if you're able to continue with your presentation?
So, hi, I'm not quite sure at what stage you lost me. And maybe it rather than continue the presentation, maybe we could just have the discussion, because you have the slides anyway. I'm afraid the internet going all the time. Is that okay?
Yes, I think that's okay, Prof. And maybe we could have a couple of questions from the audience. Would you be fine with that?
Yes, of course, yeah.
Yeah, I guess we can start having some questions rolling in the chat. And then in the meantime, we did have some engagement from our social media followers. So I'll maybe just ask a question to get the ball rolling from our social media followers.
So if I may add, I see there was a question in the chat, Jimmy, around that was from Juliet that I tried to answer, but it was directed at you. It says, in Africa, we have our own tried and tested solutions to address public health and health systems gaps. What advice would you give us to focus on testing and implementing our own African solutions without influence from the global north, even though it is mostly the global north that finance the interventions? How can we control and influence our approaches and solutions? Thank you. It is in the chat. I'll repost it.
Thanks very much. Yeah, that is such a good question. And I'm currently traveling with a group from Wellcome Trust, and we're visiting various African centers that welcome funds. And what we're communicating to people is that the first thing to note, we at Wellcome have certain priority areas that we're focusing on. but they should not conform to our priorities. I mean, there may be some overlap, but it's much more important for them to decide what is a priority in the African setting where they work and relate to that. And we would like to be able to support them to deal with their priorities. So I think there are opportunities for African researchers together with other stakeholders to identify the areas that they want to work in. And I think that you will see more and more, hopefully as we go forward, that funding will become available to support that. I think there's still funders that I will not name today, but I think you might be able to work this out, that believe that, they need to find a silver bullet for particular diseases, often infectious diseases, because it will really look good if their name could go down in history as having solved the problem through developing a new drug or vaccine. But, that is really very colonial type thinking, which I tried to talk about earlier in the talk. I'm not sure if you heard that part, but I do think that there is an awareness now more and more that we need to support people in African and other low-income settings to deal with the problems that they are grappling with, rather than coming with our own priorities. I don't know if that's helpful.
That was a very comprehensive response, Prof. We have another question from Prof. Geduld, and she says, one of the techniques that we don't often leverage is clear national strategic agendas. Ministerial support may be a useful way to direct funders. How do we as Africans create strong national strategies on health priorities?
Yeah, again, very important. We've just come, for example, from the African Health Research Institute, which is in KwaZulu-Natal. And they are extremely engaged in looking at priorities, strategic priorities for South Africa and the Southern African region. They engage routinely with universities, but also with policymakers. And they were actually asking for support with doing that, to a larger extent, support from Wellcome, which is the organization I represent, in engaging with policymakers and facilitating, hosting such discussions where we develop strategic priorities. Look, I have worked at the Medical Research Council in South Africa before, and there is a risk that people get engaged in discussions about strategies that can last for a very long time and not end up with agreement on things. And so, one has to kind of balance that, because, different people have different interests. And very often researchers are at the table and they have their own research interests and agendas, and that plays out in these strategic discussions. So I think government does have a responsibility to lead in this area, to ensure that we focus on the things that are the issues that are most important to us. But I think governments also, and researchers and governments, fall into this trap of always defining priorities in terms of diseases. So, it's always defined in terms of, HIV, TB, in the South African setting, or diabetes, non-communicable diseases, etc. Rather than saying, well, can we have research that deals with the underlying issues that actually contribute to more than one disease at a time? and so forth. So I think, you know, it's complex, but it's certainly important to be led by a vision and a strategy, and then it's easier to bring funders in that can help you address those strategic areas.
Thank you very much, Prof. I think if Prof. Geduld was happy with that response, you know, you can indicate through the chat. And I think maybe now we'll do one more question, and then because Prof does have to move on to another meeting at 6:15. So we're going to do one more question now, and then we will let Prof go. So Prof, here's another question from Gabriela Caruelas, and she asks, what about the private and public partnerships in research and development initiatives? Any good examples from within Africa and from African industry partners?
Well, I think the most recent example around vaccine development for COVID is probably one such example. You know, the COVID has sort of spurred this area of research where, you know, during COVID, we realized that we were so dependent on rich countries to provide us with vaccines that we don't want this to happen again. And so we are preparing for future pandemics and epidemics by building our own capacity to develop not only COVID, but other vaccines in the future. And that is essentially happening through public partnerships. And I think that's probably the best example I can think of at the moment.
Thank you very, very much, Prof, for joining us tonight, and even given the extraordinary circumstances. And thank you for trying again to join. We definitely will do more to thank you. And we will now move on to introduce the next speaker.
Thank you very much for the opportunity, and I'm sorry that you know, I was not able to give the whole talk, but maybe at some other time we can do that. But I enjoyed chatting with you and enjoy the rest of the webinar.
Thank you very much, Prof.
In terms of introducing the next speaker. Thank you everyone for being with us even through all the technical difficulties. We'll be moving on to the next speaker who will be speaking on the topic, Dr. Tom Machuki. So Dr. Tom Machuki is a physician and is trained in public health. He has an MPH, infectious diseases and tropical medicine at the University of Pretoria in South Africa. He has a PhD in health services research and from pharmaceutical policy from Utrecht University, and an MBA from the MT Sloan School of Management. Tom has his postgraduate training and research at the Institute of Health Metrics and Evaluation, where he also held a faculty position. Tom has held roles of increasing responsibility in public health services and at various academic institutions within private sector organizations and corporate foundation. He's active in the healthcare entrepreneurship, innovation, and research, with a specific focus on digital health and data analytics. Tom Machuki is currently the Senior Director for Strategy and Impact at the Africa Institute of Health Policy, where he leads a global portfolio of public health and community development investment projects focused on the reduction of harmful use of alcohol and catalyzing social entrepreneurship. Tom is a medical doctor who's practiced as a clinician before embarking on this career in global health, business and academic research at different countries around the world. And we're privileged to have Dr. Tomotoki Ochoki with us today to speak on the topic of health equity. Over to you, Doctor.
Thank you very much. Can I have a chance to share my screen? And I'd like to take this opportunity to thank Professor Renee English, a good friend of mine, for inviting me to this presentation today. I listened into the previous speaker and a couple of very interesting conversation that is aligned to what I'm going to talk about today. So really a great opportunity, and I want to thank everybody. I see so many familiar faces who are so many familiar names who are participating and who I've worked with before, and others. So I look forward to a vibrant conversation. I'll be taking a few minutes to briefly present my title. The title of my topic is a good segue to the presentation that the previous speaker, Professor Volmink, gave. And it's entitled to Health Trends, Inequalities and Opportunities in Africa. Interestingly, the title is very similar to a paper that we published with a couple of colleagues a while ago at the University of Washington, focused on the subnational burden of disease trends in South Africa. So there is a paper that is actually having a similar title to the title of my presentation. A small caveat, so just a small clarification. I'm representing the Africa Institute for Health Policy, which is I think a research agency based in Nairobi, in Africa. So the outline of my presentation really speaks to the epidemiological landscape in the region. Talk briefly about the health financing trends, and I think there's a question that came up about how do we finance our healthcare systems. Talk about performance assessment, and also drill down to the subnational level and opportunities for impact. Briefly, what the Africa Institute of Health Policy is a research and technical advisory agency based in Africa. A couple of my colleagues are actually on the call, and when any questions come, they might be able to help me in answering those questions. Our primary objective is really to improve population health by conducting actionable research and catalyzing the creation of scalable technology solutions that address the pressing population health challenges facing the African continent. You can see our website here, and please feel free to visit this website and learn more. The epidemiological landscape of Africa. But before I go to that, I just want to preface a few things here. The health system framework as defined by the WHO. I think many of you who are in the healthcare system, scholars and student researchers, have seen this framework that really speaks to the 6 pillars and the expected outcomes of the healthcare system. So it really gives you a very good framework lens through which to understand how the healthcare system is performing. So it will give you aspects of understanding how you're dealing with improvements of health, how this health system is responding, how there's financial, social risk protection, and how the services are being provided in terms of what kind of efficiency or inefficiency thereof, or lack thereof. So that is some of the things that you want to look at when you're looking at a healthcare system. And the system, the building blocks are really those components that are responsible, that are supposed to work together to lead towards the kind of outcomes that we are seeing here. In my talk, the next slides, I'll be showing you a trend of what's happening in the continent of Africa in view of the different, over the last 30 30 decades, 3 decades, sorry, 30 years that is. And I will be using the measure of the disability adjusted life year, which I'm sure most of you are aware of. It is really a combined metric that combines both mortality and morbidity in terms of quantification of health loss. So you can see that the premature mortality and the living in disease or disability, when you combine it, you can actually have what we call years of, disability adjusted life years, which is years of life lost due to premature mortality and years of life lived with disability. So those, when you combine them, you can actually understand what is happening in terms of the health loss in an individual or a population. So this is a population measure, and that is what I'll be referencing this as I try to illustrate what's happening in the continent of Africa in the different countries around the world. So, and I'll go through this very quickly. And this data, I must say, is actually publicly available at the Institute of Health Metrics and Evaluation, where I was working previously. And this data is publicly available, and just want to make sure that I reference that. You can be able to see that there's been a couple of changes around different parts of the world in terms of disease burden. And here I'm showing disability adjusted life years per 100,000 population, all causes, all diseases, and both sexes. And you can imagine, you can see that there's a lot of progress. So if you look at the blue color is really showing that where there has been annual change in terms of mortality, of the disease burden change per year between the year 1990 to 2019 per 100,000. And you can see that a country like Ethiopia has done a lot of progress. There's been a remarkable progress. There's been a lot of progress in countries in Africa over this period. Of course, you know that different countries start from different baselines. So that's something that you have to account for as you interpret this data. But you can see that there has been a lot of progress. So there is, apart from a country like, Lesotho, which has not had as much progress, but you can see that there has been progress over this period of time. When you look at the 1990 to 2000, if you look at that period of time, the same map shows you that over that period between 1990 to 2000, there was a huge increase in disease burden, that is the disability adjusted life years, in a number of countries in Africa. And you can imagine this is really showing what happened in terms of the HIV epidemic, which was really ravaging parts of Africa. But you can see here also the Federation of Russia and Mongolia, where you can imagine there was a lot of, after the breakup of the Soviet Union, there was a lot of health loss that was occasioned by different health trends, which probably could be attributed to the breakdown of the system and harmful alcohol use. But really, I will be focusing on the African continent, and you can see that there has been a couple of changes in terms of increasing burden between 1990 and 2000. But then there has been a reversal of fortunes. If you look at 2000 to 2019, significant progress. Countries like Ethiopia, Uganda, Zambia, and of course Botswana, and other countries in Africa. So the trend has really been quite positive between 2000 and 2019. Well, except Libya, and I saw there's actually a participant from Libya. There has been, of course, because of the social unrest in that country, that has those gains have been eroded, and that's why you're seeing these. But as you can see, overall, there has been a lot of progress in the region, in terms of making progress. But of course, it's not equal. There is inequalities around the different countries at the national level. So there's a lot of progress, but of course, and I mentioned that these countries are starting at different baselines in terms of disease burden levels. What are the risk factors? The previous speaker talked about really trying to understand, not only looking at the disease, but look at also what's driving these diseases. So there's an aspect of risk factor examination. If you look at the Southern Sub-Sahara, unsafe sex is the leading driver of health loss, and of course HIV. That is 2019, still a persisting issue. And of course, aspects like low birth weight, high body mass index, high blood pressure are some of the drivers of that. You can see the same as another trend in the East Sub-Saharan Africa. Of course, there's a change here that you're seeing low birth weight being high, unsafe sex is around number 4. There is malnutrition, which is also number 3 there, and of course, aspects like particularly in the air. West Africa, similar trend. You can see the kind of trends you're seeing there in terms of risk factors. And of course, you can see that unsafe sex really is very low in this region, but you can not really low, not very low, but it's actually relatively lower than the other issues here dealing with sanitation and others in this particular case. You can dice this data in another different fashion where you're actually focusing on the age group 15 to 49, disability adjusted life years, and you're saying you're looking at what is the risk factors which are contributing in terms of ranking to these, what has been the changes between 1990 and 2019 in terms of the ranking of risk factors for these age group of 15 to 49 years old. You can see that in Southern Sub-Sahara, alcohol use used to be the top, but it's actually kind of lower. Unsafe sex is higher, but the previous speaker also talked about things like the blood pressure, body mass index, but also you can see the huge burden which is due to things like intimate partner violence and and other conditions that are quite interesting to observe. And you can see how they're driving the disease, the burden, the health loss in these particular parts of the world. Non-communicable diseases, the previous speaker spoke about that, and you can see globally there has been a big increase of those conditions. But of course, in some regions, there has been progress in addressing some of these issues. And you can see that there's red, but also other regions, there is a couple of progress. So for instance, interestingly, South Africa, there has been progress in tackling the NCDs. And of course, I must emphasize that we are starting with different baselines, and that's the reason why we are seeing this kind of a trend over time. And this is, as I mentioned, it's annual change, and all the countries and all the data I'm showing is age standardized. So they are not the demographic effects of the population have been controlled for. So you're actually comparing apples with apples across the different countries. So the key message here for what I've shown you over the last few minutes is there has been significant progress in addressing disease burden across the region, but progress is not uniform. And this is across the world and all other places. It's not uniform, and there are key drivers that are really driving these priority risk factors, which are related to NCDs, are on the rise in some of the regions. But also, we have an unfinished agenda of the communicable diseases. So you saw unsafe sex and other factors, which are quite significant in driving health loss in this part of the world. So let me switch gears and talk briefly about the health financing trends in the region. And here I will be talking, and I think this speaks to some of the questions that were the discussion that we had from our friend from Kenya, who asked about who really controls the purse strings, and how does that affect the health outcomes, and how we determine what we invest in and how we improve our health systems. And I think Professor English gave a very, very good answer that really spoke to what this graph is showing us. You can see that in the Southern African sub-Saharan region, between 1995 to 2019, the government government spend is quite significant. You can see how much the government spend, which is in blue. There is very little out of pocket, you can see. And of course, look at the scale on the y-axis so that you understand that these in billions of dollars. And this is the different countries in the southern sub-Saharan region. All the dollars are adjusted to the 2021 dollars. So we're comparing apples with apples across. And you can see that there is a very little inflow from the development assistance for health, which is in green. There is quite a significant private prepaid, which is insurance. So you can see that there is a very, very self-sufficient system in most of that part of the world, and largely driven by countries like South Africa, Botswana, and Namibia, which are investing heavily into the healthcare system. If you look at the Eastern Sub-Saharan Africa, you can see that it's a huge green here, which is really donor dependent, and there's a lot of driving of that agenda, as the last previous speaker spoke. There's quite a significant out-of-pocket expenditure, and also government spend, in as much as it's increasing, is increasing at a slower rate, but it is increasing. In every case, it's actually increasing. So that really shows you the picture that there is increasing. There's a very different picture from the Southern Africa, which is really very much government driven and huge private. There was a huge private prepaid insurance, but in Eastern Sub-Sahara, you can see it is not as much, and you can see a big out-of-pocket spend there. Western Sub-Sahara region, Western Africa, that is, you can see government spend is also not growing at a very rapid rate, but there's a huge spend in terms of out-of-pocket spending, and also there's a donor-driven assistance from there. So really what it's showing you is that there's increasing financial allocations for health across the region. It doesn't matter where the money comes from, but it really shows you that in some cases, government in all the regions, government spending is increasing, but at different rates, which really drives inequalities, but also the buckets from where the money is coming from really has also big implications in terms of how the healthcare system decisions are determined. But there is whatsoever, in any case, there is quite a significant increase over time, and that is good for the region, and this presents a huge opportunity. So that really shows you the inequalities in health financing, and and that really also drives the outcomes that we see in some of these regions. Let me also talk briefly about the fundamental health system performance assessment, which is really just to go back to this pillar, and there's work that I would advise you as a student, especially just to this work is available online, revisiting health system performance assessment in Africa, a landscape in transition. I did some of this work when I was at University of Utrecht, and it really was anchored on this framework where we want to look at how does the different pillars work towards determining what we see in terms of outcomes. And you can be able to look at trends or inequalities across all these pillars. So think about the disability adjusted life years trends I was showing you around different countries. It's really how the healthcare is being improved across different geographies. The financing that I've talked about is also just showing you the differences but also there are other aspects that you can look at in terms of health workforce, service delivery, and other aspects that can be relevant in determining the outcomes that you're seeing in the healthcare system. So one of the things that is very fundamental in this is really understanding the subnational trends, because one thing that is clear is that you can have one country, let's say in the United States, which will have a very, let's say, very high levels of health attainment. But in some counties, if you drill down to the subnational level, you'll find that there's some counties in the United States which have as worse health outcomes than, let's say, a sub-Saharan African country in East Africa or other places. And also within in Africa, for instance, in South Africa and in other places, Kenya and other places in Africa, sub-Saharan Africa, you'll find places where pockets of excellence, where there are people who, there are populations that have access, which is as good as some countries in Europe. So those are some of the things that you want to look at, because if you don't look at the subnational level, you will actually mask those. The national estimates often mask the subnational differences. So it's important to drill down to those subnational differences. This paper that I'm talking about, Health Trends, Inequalities and Opportunities in South Africa, is an attempt to do that, that looked at the different provincial health trends. So really drilling down to see what are the differences across the different provinces and what is driving health loss in those. There is another paper which was also done in Kenya, which looked at the 47 counties between 1990 to 2016, looking at the same picture and trying to understand the same framework in terms of what is really driving health loss in those counties and what are the risk factors in terms of explaining those kind of trends. The other piece of work that I'm highlighting here is really looking at efficiency in terms of, you can also look at the technical efficiency of the different subnational units or country level, and try to understand what is driving the performance of that healthcare system. This is, I think this slide should have come earlier, just to show the differential attainment, both male, female, across the different 54 countries of the African Union, and seeing that there is differences, and you can rank these countries and you can see what kind of conditions are really driving health loss in these countries. And this is in 2019 for female and male across the different countries. You can see that, as I showed you, Lesotho is and places like Eswatini are not doing very well, probably driven because of communicable diseases like HIV. Tunisia, Algeria, Libya, in as much as there's been a lot of social unrest in that part of the world, they still do have quite relatively good health outcomes. So does Mauritius and others. So this gives you also a trend of really understanding what are those drivers of health loss in different regions. The subnational ranking of healthcare, the different conditions which are driving health loss in South Africa. I wanted to show you this because I'm talking about the subnational burden of disease. You can see that in Eastern Cape, HIV, around actually the entire South Africa, HIV is ranking top in terms of the health loss. But then if you look at, let's say, respiratory infections at the second level, South Africa, in as much as South Africa is having health loss of the ranking respiratory infections and TB as number 2, Gauteng is actually having that as number 4. The maternal neonatal is, maternal neonatal is number 2, and then there's quite a significant contribution to things like cardiovascular disease. Western Cape, you can see that something like respiratory infections is going to number 9. Number 2 is really neoplasms. So there is, of course, a couple of differences in the countries, in the specific countries, and you really need to understand those so that you can be able to understand where to direct your policy attention. This is a little bit too busy, but it's because Kenya has 47 counties, and you can see the different gyrations of the ranking of the different conditions that you're seeing here. HIV being number 1 in Kenya, but of course in a country like a county like Baringo, you're seeing that it's number 8. What is really driving health loss is neonatal disorders. So maybe they need to have a newborn unit set up or something like that, or you can actually see other places like Elgeyo Marakwet, HIV is number 7, Wajir, HIV is number 10. So in essence, it is important that we look at the subnational the subnational trends, so that then we can be able to understand what is really driving health loss in those places, so that we can direct policy attention effectively. If we only look at the average and say we're only focusing on HIV in Kenya, so places like in Wajir, which having a different need, let's say diarrheal diseases, might be ignored. And of course, as we are seeing an increasing, a rising a trend of non-communicable diseases, it is important that we really have a clear picture of what's happening at the subnational level in order to make the right decisions in terms of policies. This is a little bit too busy also, but this is just showing you the improvements which have happened across the country in Kenya. And it's there's a paper on the health disparities in Kenya, and it shows you the differences in terms of years of life lived in disability, which is really a measure of morbidity, and years of life lived with years of life lost, which is a measure of mortality. And you can see that there has been quite significant progress in reduction of mortality, especially due to investments in things like maternal and child health. Years of life lived in disability is a little bit slower in changes, but that is just because there's quite a significant rise in non-communicable diseases. As I mentioned earlier, you can look at inequalities using different lenses. So here we are looking at intervention coverage, which is really how the population is utilizing those health-saving technologies. And here we're looking at insecticide-treated nets, ITNs, and also exclusive breastfeeding, which is basically measured as an intervention here. You can see there has been a lot of progress in increasing the access to ITNs between 2000 and 2010, and this is largely because of the investments which have been made in terms of addressing the malaria, which was a big driver of health loss in that part of the world. Using that same data, you can actually understand how efficiently the country is investing its resources, or rather the subnational units are investing resources. Here, this slide just shows you the technical efficiency, overall technical efficiency of resource utilization. And here, what this data comes from a paper which is looking at technical and scale efficiency of increasing intervention coverage in Zambia, and we compared the resources invested and the outcomes that we are achieving in terms of coverage and how efficiently that's being done. And you can see that some districts are quite efficient, while others are lagging behind in terms of their efficiency. So that also gives you a picture on how, as a decision maker, you can be quite effective in understanding the inequalities in terms of efficiency, and then be able to address them in such a way that you can be able to free up resources for impact. I'll quickly move through now the fact that I've shown you that it's important for us to really understand the full picture. So don't look at only national averages. Look at the more detailed picture so that you can be able to dice the data in different directions, so that then you can understand really where the problems, how can you be able to intervene effectively as a decision maker. The opportunities we have for impact. And this is really, I think, Professor English talked to this at some stage, and the other speaker did mention what is happening around the world. So one is the democratization and decentralization processes are leading to improved transparency and accountability for health service provision. And here I'm talking about even the conversations that we are having right now. There is a lot of democratization, where in democratization of information, democratization of funding, democratization of different aspects of how the healthcare system operates. And that is allowing us to be able to have more options, more ability, more information, and people it's more transparent, being able to understand how can we keep our decision makers or the healthcare stewards accountable. How can we be able to look at how the resources are being invested, so that then we can be able to influence and make those kind of decisions to help us to make progress. There is expanding fiscal space. So a number of countries are becoming richer. If you look at the economic progress, there's a recent report by a couple of consulting companies, I think it's McKinsey and Bain Consulting, that really show a lot of progress in the African continent in terms of the economic progress in those countries. So there is an opportunity for us to be able to be more careful and more deliberate in how we pool and how we efficiently allocate the financial resources that we have, maybe through health insurance mechanisms, and efficiently pay for those services so that we can reach and expand public health. So there is a big opportunity there, not only in advanced economies like South Africa, Egypt, but other economies. Actually, Rwanda, for instance, has done an exemplary job in trying to push the frontier in this. I'm sure others are also doing that in that regard. Bridging inequalities by leveraging digital health technologies, that we saw that during COVID. There was a lot of progress of a number of digital health technologies coming into place to improve service coverage. So there is an opportunity there to really reach those last mile regions. And it's great that we have people like Claudia Shulunani here, who is in Village Reach, where they're really looking at how do we efficiently and impactfully reach those people at the last mile. So that's really an opportunity that we can leverage and be able to move forward. Of course, improved measurement and strategic communication. Those are an opportunity where this computing power alone has allowed us to be able to, we can easily be able to have this data in such a way that we can interact with data in a more meaningful way, because if you don't have data, you're flying blind. So there is an opportunity there for us to be able to move and make progress. Improved coordination, partnership, ownership of the health policy. Here is what I'm referring to what Renee spoke about in terms of CDC. Africa CDC has really been exemplary in pushing the African agenda, improving the coordination, getting the partnership, and also driven because of this COVID. There's been a very dynamic leadership in that context in terms of how do we organize as a region, how do we engage with the rest of the world as a region, so that then we can be able to work on ways to improve the health system in a structured way, and also other countries can coordinate and work together. So there's a huge opportunity there. Another one that I want to talk about is really the Africa Continental Free Trade Area, which is an offshoot of what's happening within the African Union, which is by having an integrated market that will have huge repercussions and which could be positive in the healthcare system of the African region. it's easy to move labor across goods and services. So there are a number of countries which are very good in their manufacturing capacity. There is a lot of opportunity in terms of negotiating as a large market. You know, if you're a large market, the innovator, the key pharmaceutical companies and technology companies which are investing in healthcare technology can actually be willing to engage with the region because they know that they're getting into a market where they can be able to have a return on investment, but it's also it's a growing market. So by having the Africa Free Trade, Continental Free Trade Area, there is an opportunity there that is going to have huge repercussions in the healthcare system. And you guys as young students, I mean, the students who are going to be the future leaders of this particular discourse, it's something that you need to watch and really study very carefully to see how you would be able to be relevant in that equation. There is a report by the World Economic Forum that was actually talking about that. I saw Chido Munyati, who is the Africa director from the World Economic Forum, was writing that. And there's also another report by McKinsey and Company, which looks at Alliance on the Move. It's looking at a number of economies in Africa and how they're growing. So there is an opportunity there to see as healthcare stakeholders, how do we leverage that to really improve the performance and really improve the public health. And also, I just wanted to emphasize that for those who are, especially for the students, the understanding how to measure the performance of a healthcare system is the lens through which you can use to really understand the trends and also understand inequalities and of course unlock the opportunities. So this is another space which is just talking about the supply chain, but in the interest of time, I will not go into more details with this. But yeah, thank you so much. This is our contact information. Feel free to reach out to us and in case you have any clarifying questions, but I'm happy to take any questions as we move forward. Thank you.
Thank you very much for your presentation, Dr. Achoki. That was very educational and informative. So now we're going to open up the floor for some questions. So you can maybe write some questions on the chat. You can raise your hands. And we've been seeing some very wonderful contributions here in the chat box. Dr. Shilumani here, I think to just maybe start off questions, Dr. Shilumani was talking about pooling funds and especially getting help from the diaspora and like global African, the global African community, and pooling funds to finance our own healthcare systems. So Dr. Achoki, can you maybe talk about, you know, what do you think about this idea of pooling funds and getting help from the diaspora and the global African community to finance our own healthcare systems?
I certainly believe there's a huge opportunity in that. Thanks, Claudia, for that question. And I certainly believe that especially when you think about the gap in health innovation or technology, there's a huge transition happening, evolution happening, especially in the artificial intelligence, data science space. There is a lot of disquiet, especially those who are involved in startup, you know, the innovation. I know Cape Town, where Stellenbosch is based, there's a university is based, there's a huge startup environment or techno innovation group, and also in Nairobi, Lagos and others. And I know there is a lot of disquiet that the funding always goes to the expatriates and not necessarily to the local innovators. And I think that also talks to the question that Dr. Juliet from Kabarak asked, how can we be able to do this? And I see an opportunity where the angel investors, the different aspects of African capital, especially the remittances which are coming back to Africa to buy pieces of land and other things like that, they can also find a way of being channeled into those opportunities of investing into African-grown technological solutions that really address the need. And there's a return. So it's actually being able to direct those diaspora investments in such a way that we catalyze the innovation engine, which is targeting healthcare. There's very good case studies of places like in India where that has happened, where there was a lot of diaspora investing, going back and investing back in India, and now we have places like Bangalore which are doing very well. The same in China. So that is something that I believe as the African diaspora gets organized in partnership with the different local frameworks that we have, the different networks that we have in country. There is an opportunity there to make a lot of progress in health, especially on the technology front. Getting those solutions and those would be quite transformative.
Thank you for that comprehensive response, Doctor. Maybe we will do one question now in the interest of time, and then we'll start closing tonight's webinar. I don't know if maybe someone wants to ask a question, or we'll just take from our social media engagement. So one of the questions on social media, Doctor, is that how can we ensure that marginalized voices are heard and represented in healthcare decision-making processes?
I think that's a good question. Thank you for that. It's a political process, and we're in a better space. You know, the previous speaker talked about the colonial past of global health, and there is, you can imagine the kind of progress we have made. There is an opportunity there. Now young people are doing TikTok. You know, you can be able to raise your voice and be heard. There is the cell phone the smartphone has become a very powerful tool in getting people to raise issues. You know, nowadays you can't hide anything. So I really see that technology has been very empowering to the marginalized populations. And of course, we have to continually make sure that decision makers are held accountable, because that what I was talking about, the democratization of the and decentralization of systems, is a very empowering a framework through which we ensure that marginalized populations are heard and marginalized sections of the population are heard, and that they're being able to be counted in terms of addressing the healthcare system and healthcare public health. I can see Elizabeth has a hand up. Elizabeth.
Yes. Thank you for answering that, Doctor. And sorry to Dr. Elizabeth, I didn't see the hand. So we will just squeeze in Dr. Elizabeth, and then we'll start closing.
Hello, thank you. I know my question to Daktari is about funding for areas like pharmaceutical research, especially drug design and development, because one of the big challenges we have is a lot of the high-tech equipment is really expensive, and it's mostly in the developed countries. So how do you see us getting more support for African researchers, especially young people who are interested in areas of drug design and development, to get support and funding to do this research to support the clinical areas?
Certainly. Thanks, Elizabeth. What I would say is really we have to start somewhere, and I think it's Renee who said let's start somewhere. And I believe there is now, especially with what I talked about there, the Continental Free Trade Area, those kind of policy changes, or rather getting a big market, would probably be leading to opportunities where large drug companies can see opportunities for joint ventures. You know, being able to say, well, there is a big market here. We want to easily be able to do our clinical trials in that particular place. So there is a huge opportunity, especially with the integration and being able to have opportunities where the market becomes attractive. The talent is there. That's one thing I'm very sure about. And maybe that aspect of joint ventures which have worked in Asia, if you see how Asia has been quite transformative in the space of technology, that is something that I think the African continent needs to look at in all phases, in all spheres of technology, not only healthcare, but other spaces.
Thank you.
Thank you very much for that, Doctor, and thank you for your presentation and for taking time out of your day to come and talk to us today. We definitely have learned a lot, and we hope to, you know, have more platforms like this in the future. And I'm so sorry for questions that we haven't been able to get to. Yes, so now we will move on to the closing. So I will hand over to you, Tolu.
Perfect. Thank you so much. I'd like to extend a warm thank you to every single person who's taken the time out of their Wednesday evening to join us for this webinar. I'd like to extend another warm thanks to our speakers for the night. I believe everyone is going to leave equipped with new knowledge and burning for global health and how they can take what they've learned and apply it into their various spheres. Before I close, I just want to draw everyone's attention to the chat. Our fellow colleague Stacey Blouse left a link for an anonymous survey that we'd like you to complete after this meeting concludes, just to give a little feedback so we know how we can improve and what you'd like to see from us in the future. And on that note, I just want to thank every single one of you again for joining. To the core team, thank you again for availing yourselves and making this a fabulous webinar. And I hope that everyone enjoys the rest of their week ahead. We look forward to seeing you at our next webinar, so keep a lookout for your emails and we'll let you know when and where that will be. Thank you, everyone.
Thank you very much.
Goodbye, everyone. No hard feelings if you leave the Zoom call now.
Thank you.
Take care. Bye.
Goodbye.
Thank you. Bye, everyone.
Goodbye and thank you.